Well, I've been here about a year and a half, and it's a great facility. I think our staff and our leadership here at the Veterans Home is great. And the partnership we have with Rocky Vista is great. It's one of the reasons I came down here. I spent about the last 30 years in Utah as a rural family physician, and I was up in Richfield. And when I heard about the university being built down here and being next door to the Veterans Home, I thought it was just a perfect match for me. And being an empty nester at that time, I convinced my wife to come down and join me here for this opportunity. For about the last 30 years, I've been a medical director of a nursing home up in Richfield. I'm a certified medical director, and about 18 years ago, I took some extra studies on hospice and palliative care, which was a new thing in Utah about then. And so I studied and became board certified in that. It's been my passion since then to make sure that our older population is getting the proper care and transitions of care from hospital back to community and nursing facilities, assisted living, and of course end-of-life care. And so I'll kind of run through this presentation here. My objectives, I teach over at school, so I have to have objectives, right? So we're going to learn about end-of-life care and debunk some of the common myths and misconceptions. Many of you hear things all the time about hospice and end-of-life care. Most of it is not right. Of course, but it's a very emotion-filled type of a time of life anyway. And we'll learn more about hospice, about debunking some of these misconceptions and myths. There's an author by the name of Atul Gawande. I don't know if you've heard the book Being Mortal. It's a good fast read if you need a book to read, but I would recommend it to everyone. He is an oncology surgeon, and through his experience with his father and his family, he learned a lot more about end of life and what it really is than what he had been doing in the past. And he had asked a question: what should medicine do when it cannot save your life? Tough question. Because we live in this world of modern medicine. And modern medicine, it just amazes me to see the explosion of the technology and everything. When I went to school 30-some odd years ago, and then what I'm seeing being taught now in medical schools and in teaching the students, it amazes me the amount of technology that's come around. And here in our own little community in southern Utah, Dixie Regional Medical Center is one of only a handful of communities that are doing replacement of diseased heart valves through what we call keyhole surgery through a catheter to here in small, rural Utah. And so this helps restore that blood flow to organs in the body. And I'll back up a little bit. Modern medicine has 4 different goals. And the main one, and rightly so, is to cure illness, right? Well, the other 4 are oftentimes put on the back burner a little bit with that. And so that's like prevention of disease and illness. It's also health promotion. And the one that I'm going to talk about more is the relief of suffering. Benjamin Franklin once said, nothing is certain except death and taxes, and we all know that. And we all know that all will die, and modern medicine, as hard as it tries, has yet to make even one person immortal. One of the things I like to bring out here is that no one should die alone, in fear, in pain, or in distress. And we see too much of it in our days right now. What I hear too often is a statement on the top here. And I think you guys hear this too, and I hear it from physicians even. And that is, there's nothing more that I can do for you, so go home and put your affairs in order. I would get patients who would be up and see their doctor, and they'd come down to Richfield, and they'd be back in the emergency room the next day because they were left alone and didn't know what to do. Another thing that I hear from a lot of patients and family is, when we talk about hospice, is it's too early to go on hospice. I'm not ready to die. And that also is wrong. Hospice, we're going to talk about it, what hospice is. If you see the picture to the side there, whenever I talk about hospice, this is what I feel like people see me as. The big Grim Reaper. They're not ready, so I'm going to have to get a costume sometime. What your physician should really be telling you is, when cure is no longer possible, the healing physician assists with comfort and life care. There was a professor at Johns Hopkins University, Sir William Osler, and he declared this as a motto for physicians: to cure sometimes, to relieve often, but to comfort always. And that's kind of my motto here, is that we should really be putting out as much comfort care as we can. There's a whole bunch more we can do at the end of life. It's said another way here that in most cases, dying like birthing is a process requiring assistance. Now think about that. We spend a lot of time OBGYNs and delivering babies, but we don't spend as much time and give as much help in assisting people in this part of their life. The big problem right now is something called the silver tsunami. And so I'd like you to look at those statistics there. It began in 2001 when the baby boomers, which I'm part of, is turning 65. And 76 million Americans were born between those dates of 1945 and 1964 that were called baby boomers. And there's a lot of us here in the room. This is going to double and triple in the next several years. So the number of people over the age 85 will increase by fourfold by, they say, 2050. Just by 2030, 1/3 of all adults in the United States will be over the age 65. So if you look at that wave there, we'll be seeing this type of a picture here a few more times. The silver tsunami, 72 million Americans by 2030. Betty Davis said it this way. She said, "Old age ain't no place for sissies." Right? Okay. Dick knows that. Here's that same picture there, as you see that go up. These are people that are age 65, and it's getting, that percentage is getting higher every year. That looks like that tsunami again. There's a book here that said, "Old age is always 15 years older than I am." And that's my motto here, okay? So no matter how old I am, old age isn't until 15 years older than me. Longevity's changed a lot. In 1900, as you can see there, pneumonia, tuberculosis, diarrheal illnesses like cholera, and things like that were the main thing that caused death. Those are infectious diseases, and unfortunately, with our public health system, we've cleaned up the water, vaccinations have come around, antibiotics, and other things, and it's helped us live much longer and healthier. And so now you see that the number one cause of death is heart disease, cancer, stroke, chronic lung disease, then the accidents and injuries, Alzheimer's. How many here knew that Alzheimer's is actually a cause of death? A lot of the public doesn't know that. Diabetes, and then we get down to that influenza, pneumonia, and other infections and things. Woody Allen said it this way: "I'm not afraid to die, I just want to be there when it happens." Here you see that tsunami picture again here with health care costs. As you can see that over your lifespan, money spent on your health care starts to go up in just that last year or two of life. So end-of-life care is kind of complicated, and lots of different choices, and that's what it is, it's choices, what we should do with that. All of us want to think of this. We all want to die with dignity. We don't want to be in a hospital bed. I think it's 86% of the population wants to die at home, in their own bed, surrounded by their family. Again, these are choices that we have with medical care. Intensive care or intensive comforting. I like this statement by Gandhi. It's the nation's greatness is measured by how it treats its weakest members. So who are our weakest members? We have our infants, and we have our elderly aging population. Hospice is one of my favorite things that I've learned about and been able to be involved with for nearly 20 years. It's a team approach. We call it an interdisciplinary team of professionals. I keep saying we should have our own hospice here because we have all those professionals here in this facility. It's made up of your attending physician as part of this team, a medical director, which I've been doing for many years, supportive therapy, which we have here, social workers here, registered nurses, so this is run by the nurses basically, hospice aides, volunteers, some of you have probably been hospice volunteers, and we have chaplain and spiritual support also. So it's a team approach. So let's learn a little bit more about hospice by debunking some of these myths about hospice. Cicely Saunders was a British nurse, and she was one of the first to use opiates. She went back to school and became a physician, and she used opiate medications to alleviate the pain and suffering of the dying patients that she was taking care of. And so the myth number one here is hospice will kill you with morphine. I hear that so much. We use medications, such as opiates, very skillfully in the lowest effective doses to help control pain and dyspnea. Now, dyspnea means the pain of breathing, shortness of breath and air hunger, and other distressing symptoms as a hospice tool for end of life. Myth number two, hospice will euthanize you or hasten your death. There's nothing more wrong than that statement. Hospice affirms life. It neither hastens nor postpones death. With early patient referral, and I'd like to underline that early referral to hospice care. In the last months of life, patients live an average of 29 days longer on hospice than patients who are not on hospice with the same conditions. And we'll talk a little bit about later on why that is. But yes, hospice patients do die. Not because they're on hospice, but because they have a life-limiting disease and illness. Myth number three, hospice will take away and stop your medications. Again, this is wrong. Any medication, any current medication which is there for comfort and which is beneficial for the patient to feel and function better should continue. However, many people are on a lot of unnecessary medications. Some are actually harmful with interactions and other things, and these can be what we call deprescribed and removed. And oftentimes patients feel a lot better, all of a sudden have a new zest for life and do much better without some of these unnecessary medications. Myth number four, hospice will force you to stop eating and drinking. Again, hospice encourages people to eat and drink what they want. Good nutrition is always encouraged. It won't force anyone to eat or drink. However, sometimes oral intake, such as foods and solid food, can become a burden or a hazard when the risk of aspiration is high at the end of life. Myth number five, hospice is giving up and dying. Hospice is all about life's important moments. It's these choices and goals. It may not add days, but adds life and quality to those days, weeks, and months. So the focus of hospice is not on the disease, like the curative model of medicine, or that disease process, but it focuses on comfort, dignity, support of the patient and their family and loved ones. And I found that comic and thought that was great because we have great nurses here in this facility. Myth number 6. Hospice is only for the last few days of life. Unfortunately, we see that too often, that early referral doesn't come. And then it's what I call brink of death care, because it's just for the last 24 hours or so. But the Medicare hospice entitlement benefit, and I don't know, do you know that it's an entitled benefit that you have to Medicare? That was set up in 1983 by Congress. But this benefit is for 180 days and as many 60-day periods as long as they still qualify and are eligible under the qualifications, which we'll talk about here a little bit later. If a patient is not admitted until they are actively dying, you have essentially denied them 173 plus days of their benefit entitlement. And who wants to deny somebody their benefit or their entitlement, right? So the average hospital length of stay is only 19 days, but 37% of those on hospice die within 7 days or that because of that non-early referral when they need to be there where they can help. Myth number 7, you cannot see your own doctor on hospice. I encourage everybody's physician to continue to take part in this in hospice care. We encourage them because they know you best and they know what you want. The hospice medical director then consults or certifies and recertifies hospice patients. And sometimes I do end up taking over the care if the physician is not comfortable in taking care of them. Myth number 8, families cannot provide care for their loved ones. We actually encourage families to provide care, and we teach them how to provide that care in their home or wherever they are. Over 40 million families in the U.S. provide end-of-life care for their loved ones, and they estimate that's 37 million hours, providing $47 billion in care. I don't know how our economy could survive that without loving families. Myth number 9, hospice is only for the elderly. Well, that's definitely wrong. End-of-life care is end-of-life care. We have peds, we have infants on hospice. It's interesting that hospice, pediatric patients can be on hospice while they are getting curative care and hospice care. In primary children, they have a very active hospice group that take care of the patients even while they are going through curative care. But again, 83% of hospice patients are age 65, and most of them over age 85. Myth number 10, hospice is only for cancer patients. At the start of hospice, that's really what it's set up for, is cancer patients who were dying in pain and very distressing symptoms. But now, as you can see, it's changed a lot over the last 20 or 30 years. We have cancer is still a very large portion of the patients we take care of, but also things like heart disease, kidney disease, strokes, and all the others that you saw on the previous graph. Myth number 11, hospice means giving up hope. Well, maybe for cure, but when cure is no longer possible, hospice provides that hope and comfort from pain, giving quality of the time, helping to heal and mend relationships. I could tell all sorts of stories about people's goals. I had one gentleman who just wanted to ride his horse back up on the mountainside where he used to herd sheep, and we were able to make that happen. We've had people who have been able to go and do things through the help of hospice. We've been able to get people through till a new grandchild is born and things like this through aggressive hospice care. So hospice helps patients meet some of their end-of-life goals and tries to allow them to have that peaceful death. Myth number 12, hospice is expensive and only for the rich. This is a Medicare aid benefit, so beneficiaries pay little or nothing for hospice services. There is 100% coverage, no co-pays or deductibles. Ever heard of that? For your patient visits, nursing care, medications, durable medical equipment that pertains to the comfort of care and terminal life-limiting diagnosis. Hospice is a 180-day entitlement, and the studies have shown that for every dollar spent on medical care, $1.52 is saved in our medical care. Myth number 13, hospice is a place to go and die. Well, there are some hospice facilities in different places in the country and world, but hospice is not particularly a place. Hospice care is provided wherever you call home. It could be your home, your family home, assisted living center, skilled nursing facility like this, or a hospital room. I go up to Richfield once a month and do home visits of patients to recertify them in their home. 86% of people, like I mentioned earlier, want to die at home, surrounded by their loved ones. Myth number 14, hospice is only for the homebound and bedridden. No, this is not like home health. We all know that home health, there are requirements to be on home health. And you have to be homebound, and you have to have a skilled nursing need. But hospice patients do not need to be homebound. They do not need that skilled nursing need. The hospice goal is comfort care, and it's reimbursed on a per diem basis. Myth number 15, once you choose hospice, you can't leave. That other than death, there's two other ways to get out of hospice. One, if you do improve so much that you're doing well, hospice will discharge you and say, come back, we'll have you back whenever you're ready. Patients can also revoke Medicare hospice benefit for any reason. Some people are feeling well or feel like they need to go try another treatment plan or care plan, and that's certainly, they certainly can do that. And when they come back on at the same benefit level they were on before. Myth number 16, hospice patients must have a do not resuscitate order. That's not mandatory. Of course, it's highly recommended. If you have a life-limiting terminal illness, every time I say terminal, I want to think about is Arnold. But in the Terminator, I like life-limiting better. Hospice provides education as to why allowing natural death may be their best choice. Personal preference for withdrawing and withholding different life-sustaining procedures and interventions will always be offered. And we have a form we call a POST form that we use here in the facility. It's the physician's orders for life-sustaining treatment. And that's filled out ahead of time so we know what your wishes are and how we can fulfill those. Myth number 17, only a physician can refer you to hospice. That's not true either. That's true for home care, but it's not true for hospice. You can refer yourself. A family member can refer you. And when that occurs, your physician is notified, and the medical director of hospice is notified, and we determine their eligibility and qualifying life-limiting illness and that prognosis. Hospice physicians are trained in prognosis. So the entitlement benefit requires two things from you, or to be on hospice. One is the two physicians, your physician and medical director, certify a life-limiting illness that meets the criteria for terminal diagnosis of less than 6 months if that life-limiting illness runs its natural course. And then the second, I've had people on hospice for 3 years. They're doing so well. They are still actively dying and qualified, but they've lived a long time. You also need to elect your Medicare member Part A benefit for hospice. So really quickly, in summary here, hospice is a care team. It's a great care team. I brag that it's the best care you can get. It's physician-directed, nurse-coordinated care for the patient and the immediate family, 24 hours a day, 7 days a week. They're available to come. That doesn't mean they're there all that time, but they are there when you need them. And with the different members of the team, as social workers and chaplains and aides and volunteers and nursing care. Hospice is about quality, not quantity of life. So hospice is for controlling pain and managing other distressing symptoms. It focuses on life, does not hasten or postpone death. It recognizes death as a final stage of life, not the enemy. It provides comfort care for people by allowing the life-limiting illness to run its natural course. It gives patients hope for comfort, dignity, and living all the days of their life. It provides care in the patient's home, surrounded by friends and family. It provides this whole interdisciplinary team we talked about. A lot of people want to know what's the difference between palliative care and hospice care. Well, palliative care basically is care given to anyone who is suffering from a disease or an illness. Palliative care should be started very early on in any severe illness, such as heart disease, such as cancer, and kidney disease. It should be started right then in taking care of those distressing symptoms of pain. So, hospice is always palliative care, but not all palliative care is hospice. Hospice is the assurance that you will not be abandoned or alone, and that your physical suffering will be carefully attended to with effective comfort measures. Hospice is trust with dignity, that your dignity will be honored, that burden to family and other members will be minimized, personal goals will be supported. There is also a 13-month grief counseling benefit to the family after a family member dies on hospice. That is a benefit covered by hospice for the family. Hospice is a Medicare benefit. We talked about that. It has 2 90-day certifications, and if they remain eligible, they may be recertified for an unlimited number of 60-day periods. And the focus of hospice is on comfort care. So, the message tonight is that end-of-life decisions should not be made at the end of life. We should make these decisions early. When we make these decisions, we should tell our families about this. They should know what our feelings are and what we want done while we're still able to make those decisions. Michael Meade said once, "We are a culture that denies death. Therefore, we are all walking back or towards death backwards. It's better to turn around." And so the reason tonight is to get us thinking about what we want. So hospice end-of-life care is not a contagious disease. You can't catch it. So let's talk about it more. Let's be more open about this discussion. Muhammad Ali once said, "Do not count the days, make the days count." So, appreciate you being here and listening. If you have any questions, I'd be glad to answer any of those questions.
So, obviously, we certainly use Medicare for most of our hospice patients, but what about a younger person that is not Medicare eligible? Can you talk a little bit about what your experience has been with health insurance?
Yes, in 1983, Congress made hospice a Medicare entitled benefit. Also under Medicaid, and also most insurance companies have a hospice benefit. It's almost all insurance companies, Medicaid and Medicare. Yes?
Correct me if I'm wrong, but I think VA also covers it also.
I believe they do, yes. I'm still new with the VA benefits. I've got to learn it all, but yes, they do cover it. So it is a benefit for you.
What the criteria is?
It can come from the patient. You know, we talk about home health care. Home health care is usually directed by the physician. So if I have a patient who comes to me and needs care in the home, and they need to qualify for a skilled nursing need and be homebound. Hospice is different than home health care. I call it better than home care because you don't have to meet those criteria, being homebound and things like that. So the patient themselves can refer yourself to hospice. And we look at your diagnosis and qualifying there's an eligibility requirements under each illness, different types of cancer, different types of heart disease, and kidney disease to qualify for the hospice benefit. The family can refer their loved ones to hospice. The physician, we hope, is in tune enough with their patients that they will refer them to hospice.
Could you talk more on palliative care?
Okay. Yeah. Palliative care now is the new branch of medicine that we're finding in hospices, or hospitals a lot now too, is they have a palliative care team. Anyone who is diagnosed at any time in their life with a life-limiting illness, or what could be a life-limiting illness, and is going through even curative care, such as chemotherapy, radiation therapies, surgical care, and things like this, know that these are very distressing times. These are painful times. The medications can be very sickening. And palliative care is given at that time to help them through this time, through their distressing symptoms, through their pain. And as that disease progresses, palliative care should even be more of a part of that care that the physicians are providing. So any physician can provide palliative care. Palliative is just palliative means to cloak the symptoms, basically. It comes from the Latin word to cloak. And so if you think about it, to cloak the symptoms of the disease, that's what palliation is. And so when palliative care, eventually palliative care can turn into hospice. Now, palliative care may be all they need to get better during their curative time, and that's great. But if that life-limiting illness continues and continues to worsen, and a person is deemed by their physician that they are within 180 days of death, if that illness continues in the rate that it is, then they qualify for hospice care. Now, physicians are very bad prognosticators. The closer you are to a patient, the harder it is, even. And so physicians have been shown to be very poor at this. In fact, they did a survey on that, and they asked people, here's a patient, here's all of his symptoms and diagnoses. How long do you give them to live? And it just looks like somebody took a shotgun and you're putting all the dots up there on how long they were to live. And this is where it takes a medical director sometimes from the outside to look at it and say, no, this person truly does qualify. Most physicians probably miss it by 6 months. They should have referred them 6 months earlier. And that's why we want that early referral, so that the interdisciplinary team of hospice can really help the patient and their families with their symptoms and distressing symptoms. Does that help a little bit on palliative care? Okay. A lot of people go through a lot of disease and are thrown a lot of medications and treatments and surgeries, and nobody's managing those distressing symptoms during that time. How many times do you hear that? You come home from chemo or you come home from radiation and you have a horrible week. Somebody should be helping you manage that during that time. That's what palliative care is.
And what's the maximum time?
You can be on palliative care forever. Palliative care is basically just good patient symptom control of their disease process. I like the term distressing symptoms because we don't only treat pain, we treat nausea and vomiting. And I've treated about anything you can think of a distressing symptoms. I had one patient who, with his disease, he developed horrible hiccups. It went on for weeks and months, and we were finally able to find something that controlled that for him. Just as maybe a minor thing, but if you think about it, it's not. You can't sleep, you get rest or anything. But there's lots of distressing symptoms that palliative care and hospice care can treat.
I wanted to ask the question, and thank you for this. This is really great. What place in hospice does therapy have? Physical therapy, occupational therapy? As a hospice provider, we often will have families say, we're ready for hospice, but we kind of like to continue with some exercises. So with those therapies as part of the hospice benefit, I was curious what your opinion is, how they play into hospice care.
Therapy is not a typical part of hospice, but it can be a part of hospice. It has to have a goal. And so if the goal with therapy is to help the patient become more mobile, less in pain because they can get out of bed better, and with less pain and things like that, therapy is very beneficial. But there needs to be a goal in sight with that.
How does that work?
And it depends on the facility. Like I mentioned earlier, I'd love to have a hospice just here. We have the team, we have the resources, and that to do that, and that would work out well here, I think. But hospice in most facilities is a hospice care team, such as we have Zion's Way and CNS here, I believe. They come in and their medical director examines the patient, looks over the records, and recommends the course of care. The hospice nurses come in and evaluate the patient at least a few times a week. The aides come in, the social workers come in, the chaplain comes in. So hospice literally takes over that care. However, the nursing staff here in this facility and in other facilities still provide the day-to-day care. We encourage the families to come in and help out also and teach them how to give some of that care. The nurses here give the medications on the schedule. Any of the distressing symptoms are referred back to hospice to talk about these. Hospice meets together a minimum of every 2 weeks, and we discuss every patient, their care plan, and their plan of care. We'll try that. And what these patients need to help them with their distressing symptoms. So I meet every 2 weeks with our hospice up in Richfield and talk about each patient. The same thing goes with CNS Hospice and Zion's Way. They also meet together and discuss the patient's care needs, and they come in and take care of those needs and direct the staff here also on the care of that patient. Does that kind of, anything else you want to add to that? When I talk to people about end-of-life care, I don't want to wear that Grim Reaper outfit type of thing, because I think it's something we can talk about openly, and I think it does help. Hospice and end-of-life care choices, it's just that it's choices. It's wanting to know what the goals of the patient is, what they want to accomplish still, or what they need from us with it. So it's it's a choice of going from a curative model of medicine to a comfort-based model of medicine and care. And a lot of the things we do, like I mentioned in this lecture, was that skillfully using medications and deprescribing medications. And we get patients with lists of 20 and 30 medications. There's many interactions going on there. There's many side effects and problems that if we can skillfully remove some of those, change some of those, use them better, use better medications, we can certainly change the way a person feels from day to day. They can sleep better, they have less pain, they can get around better, they maybe feel like eating, and things like this. And so I really think we need to have that discussion early and know what the goals are. So if you have loved ones who are facing a life-limiting disease, and our whole population is, nowadays, we're living longer with what are non-curable diseases. And when they become to that end stage, part of that disease, we need to talk to them. We need to know what their goals are and how we can help them. And hospice, in my opinion, is the best service there is.